And now, the DPP Rally Talk Show with Claudia on the Call 360 Network. And here's your host, Claudia Morandi.
For 30 years, he has conducted hundreds of clinical trials in pain and addiction. His book, The Painful Truth, has been a godsend for CPPs throughout the country. Dr. Webster, thank you so much for joining us.
Thank you, Claudia, for inviting me.
Yeah, you're hugely respected in the pain community. I know you're incredibly busy, so thanks for, taking time stopping in to see us. I'm going to get right to the questions. I've got too many here. So first off, do you still see patients?
I do not. I stopped seeing patients in 2010, and since the January 2011, I've been doing clinical research.
Okay. And what does PRA Health Services do?
PRA Health Services is a contract research organization. We call them CROs. These organizations and our organization contracts with pharmaceutical and device companies to conduct clinical trials that are required in order for the products to be approved.
Okay. And you and I, we had a conversation the other day, and we talked about perhaps a non-addictive opioid. Is that something that where you work, is this something that you're working on? Do you know anything about a non-addictive opioid coming down the pike?
Yeah, this is something that I've dreamt about since I was first in practice, because obviously it's kind of, it's kind of like the holy grail of analgesics in many ways. That is, if we could get a strong analgesic that works as well, if not better, than opioids, but without any addictive properties, and more importantly, without causing respiratory depression. And there are several of these in the pipeline now. Unfortunately, they're early. Most of them are early, so it's going to take several years before we can evaluate them completely, make sure that they're safe and that they're doing what they're purported to do. But I'm very hopeful that in a very short time, we're going to have much better medication than we currently have.
Well, that would be wonderful for the pain community. So many times when I speak with doctors, they say the same thing, you contact the FDA and have them fast-track a non-addictive opioid. And for people that are in the climate now, millions have been left to suffer. So I think when these people hear, oh my gosh, 2 more years, they struggle with that. But if we know that maybe there's light at the end of the tunnel, we could give hope to people with pain. You and I also discussed the other day the opioid risk tool. I receive too many messages to count from women who have been victims of sexual assault. They are chronic pain patients, and their doctors tell them, or they've been red flagged, they're no longer considered to be good patients with opioids because of this background of sexual assault. And when I first heard this, I said, oh my gosh, this can't be true. How cruel is this? And it wasn't until I put out a tweet and then we really started to get an overwhelming response of horrible stories of women, perhaps men, who have been victims of sexual assault as children, and they want to be honest with their doctors, but when they meet with their pain management doctor and this opioid risk tool is brought up, they can't get the pain medication. What are your thoughts on this?
Well, I'm stunned, and I'm really surprised because that's not the intent. That's a misapplication of the tool. It's very, very disappointing that physicians take, or providers, I guess, of all types, are taking the tool out of context. That in no way would a positive answer, an answer that's affirmative to a history of pre-adolescent sexual abuse or sexual abuse, should that be used to prevent somebody from receiving the treatment that they deserve, whatever that treatment is. The opioid risk tool is just an assessment of what we know are risk factors, and in this particular one, it is well grounded that it is associated with increased risk, but increased risk doesn't mean you're going to develop a problem. The risk of developing an opioid use disorder or the disease of addiction is really genetic, mostly, and environmental. And if this happens to fall into the category of environmental. So if, in a way, because it's your personal life and your experience early on, that creates what's commonly referred to as like a PTSD problem. And we know that people who have PTSD self-medicate. But that doesn't mean that you're going to develop a problem, any problem, with any substance. It's just a risk factor.
Yeah, I'm going to sneak in a caller here. Hi, caller. Hi, caller.
Hi.
Hi.
Claudia.
Hi. Oh, so Dr. Webster, I have a lovely lady on the phone, and I remember when we first spoke many years ago. Why don't you, caller, tell what's your question for Dr. Webster? What's your experience with the opioid risk tool?
Well, I'd like to just share what my experience was with this. I have Crohn's disease and psoriatic arthritis. I've had many, many hospitalizations over the course of 20 years. And about 2 years ago, I was admitted for pain control for passing multiple kidney stones at one time. And the ER doctor was fine. She admitted me for pain control. The hospitalist, when he walked in the room, the first question he asked me was,
It's okay, just take a breath. Yep.
Well, I hate talking. But he said, I've seen in the past, and he wanted to know why. So I told him PTSD, and he said, from what? And I said, childhood trauma. And he said, was it specifically sexual abuse? I said, yeah. He said, due to that, I can't treat your pain. So I said, but I've had 20 years of pain medicine off and on, never had an issue with addiction, ever. I was like, do a tox screen, you can see. He's like, oh, we've already done that, and I see you have what you're supposed to have in your system, but because your abuse changed your brain chemistry, you have a higher chance of addiction, so we're protecting you from yourself.
Your abuse changed your brain chemistry. Yep. Dr. Webster, how does a patient like Beverly, who's, has a severe chronic illness, Crohn's disease like myself, and, we get admitted routinely, how is she to battle this with years ahead of her? We're lifers in the hospital.
I was blindsided because I've had been in and out of hospital for 20 years. I've never been asked this question, ever. Been asked, why, were you abused, and because of that you can't be treated for your pain. They proceeded to let me scream and cry. I was passing 5 kidney stones at one time that were relatively large. They proceeded to let me scream for 24 hours, and then when they discharged me, they said, if it gets worse, come back. And I said, I'd rather die of a heart attack at home than come back here. And they said, you say that again, and I'll admit you for suicidal ideation, put down drug-seeking behavior in my chart, and that was it. And that's when I called Claudia. So after that, I went off all psych medication because I can't, if I have to choose between the two, it's going to be to get pain treated when I need it. So, yeah, I don't understand there's no way to fight it. I tried.
Yeah, how can Deb as a patient tackle this, Dr. Webster?
Well, first of all, let me just say that I'm very sorry that you've had that kind of an experience. I believe what you've gone through is beyond cruel, and it in no way is an appropriate behavior by the physicians, the hospitalists that treated you. It's way outside what I would consider an acceptable standard of care. It is unconscionable what they said and what they did, and there's no science to support really what they've done to you and the harm that they've done to you by just denying you treatment.
Yeah, and as Bev's advocate at the time, her post-traumatic stress was so severe.
It was out of control.
You're trying to, but millions of us, of course we have PTSD. Yeah. We count ceiling tiles when we're in the hospital for 30 days at a time. So Dr. Webster, could you write a paper in the future about this?
Well, I'm actually writing. Yeah, Claudia, when you and I spoke the other day, and you brought this to my attention, as you know, I was surprised, and I'm very disappointed in my peers out there by trying to take something that is not intended, not appropriate, and misapplying it. But as a result, today I spent, prior to this interview, I'm working on a blog that if you're interested, you'll be able to see it next weekend. I'm addressing just this issue to try to highlight how it's been misinterpreted and how harmful it can be to people, where your example is just cruel. It is just cruel. And I can't say anything that would support the physicians. It's just cruel and ignorance on their part. I'm sorry what you've gone through, and the others who are listening as well. I am going to write this blog. Please print it off, give it to your doctors, tell them that I'm the author, and that is not how this is supposed to be interpreted.
Another form of cruel treatment as an advocate, I'm called in frequently for the elderly, and it turns into a horror show because my elderly patients have to choose between their benzodiazepine that they've been on for 30 years or their 2 daily Percocet for severe spinal stenosis. And, I'm called in to keep the calm in the room, but with an elderly patient, they're fearful, and I've got a nurse practitioner that's fearful, and this happened very recently, and the NP said to me, no, there's a black box warning put out in 2016, blah, blah, blah. I said, well, that's because of the people that are overdosing. I said, this is a stable patient who's been on both for 30 years, and to make anybody choose is cruel. To make my veterans choose is cruel. I can't. To me, that's the cruelest form that this community has been hit with. Have you? What are your thoughts on that? And how can we tackle this as advocates for the patient?
So let's put this in perspective. I think I was one of the first people to publish in the literature that the administration of an opioid and a benzodiazepine increases the risk of sleep apnea. And increased risk of sleep apnea increases the risk of an overdose. We've seen, subsequent to my original research on this, that there is, at higher doses, greater risk of significant respiratory depression or an overdose when there are benzodiazepines and opioids used together. And when I first presented this literature in an abstract and then later in lectures, I suggested that there are ways to mitigate the risk. One is you make sure that you do assessments. You do a sleep study and document whether or not there is any real threat to the patient. If they need both, there are other ways to treat this. You can provide oxygen during sleep, but of course we should always look to have the least amount of both. I've never advocated, and I don't state that it's an either or, because you can't treat many people correctly if you give this forced choice upon people. There are people who will benefit from both. And so what I suggest is, again, you can do the research. You can look my name up because I've written about the guidelines of using benzos with an opioid. We want to have the lowest dose possible, but sometimes they are both necessary. There's just no way to avoid them if for some people the benefits far exceed the risks of the combined use.
Absolutely. So the next issue I want to talk about and ask you about, this is obviously, I think the root of all evil is I've got all of these doctors emailing me that are being rated. Doctors who've never had people overdose. Doctors whose job was, whose only crime was they didn't turn their back on their patient's pain. And I remember when it was one doctor. Now it's daily doctors. I've got doctors that have left the country. I've got doctors that have taken their lives. I've got doctors that have surrendered their license. I'm going to bring in a doctor right now. Hi, caller.
Hi, Claudia. Hello, Dr. Webster, Dr. Feldman.
Hi.
Lynn, you and I have never met, but we're contemporaries. I've been doing pain medicine for a long, long time. I am presently sitting in an RV park in Forest City, Arkansas, and I spent my day visiting a doctor, a fine doctor that I know, that I've known for decades, who has been sentenced to 20 years in federal prison, and he's at the Forest City Federal Prison. My simple question is this, is that I believe that we are now completely past the point of reason, and anything that reasoned people like all of us say will not be adhered to, listened to, or paid attention to. So, simple question, where do you, who I look up to, who I consider a colleague and a pioneer, where do you see this going in the short term, intermediate term, and long term?
Oh, wow. I don't have a crystal ball, but, first of all, thank you for calling in, and thank you for your compliments. And I think we are all in a very difficult place. I usually focus on the patients, but unfortunately, our patients are not able to get treatment if we are not allowed to provide them the treatment that science really dictates that they could receive. So we're in a difficult time because I think our politicians, our policymakers have felt a huge amount of pressure to curb the opioid deaths. And as you know, most of the deaths are not from prescription drugs. And where prescription drugs are involved, most of the time they are not by our patients. They've been diverted. And so it's not the prescription of the drug to our patients that's causing all of the harm. However, our patients, and then as you've just pointed out, many of the physicians are being held responsible and accountable for the larger drug problem. I think that that the Department of Justice has gone way too far in many instances of bringing actions against physicians, and that has caused a real chilling effect. It's done more than a chilling effect. It's caused the harm that you've just identified with some individuals, and it's made others fear that if they prescribe at all to some people, that they will be at risk of their freedom, if not their license, or both. So I think that the pendulum will swing back, but not until we probably bring the opioid crisis under control, and that the media begin to really address what the real core issues are, rather than finger pointing mostly to the medical profession and the amount of opioids that have been prescribed to pain patients. It's not a rosy picture in the next year. It's a real struggle, and every time a physician struggles with this, multiple patients struggle.
Mm-hmm.
That doesn't, however, let me be clear. There are some physicians who have really done a disservice to patients and to our profession. There are some cowboys out there, as there are cowboys within the DEA, that are creating havoc, if you will, within the whole system. And I think and the legitimate patients and the legitimate physicians are the ones that are paying the large price.
Mm-hmm. If I could say, first of all, I think you're exactly right. I myself have been severely damaged by all of this, but we won't get into that. But, we, meaning Claudia and I and the many, many thousands, if not tens of thousands and millions of people, we're beginning to see this as a war, not a reasoned conversation. But we look to guys like you as the voice of reason when we need the voice of reason. And you've been that, and we certainly appreciate it.
It's not without getting arrows swung at you. You're right. I try to be rational and logical. I acknowledge that we have bad docs. I acknowledge there have been far more opioids prescribed than have been necessary. But I also want people to understand there are people who are suffering, and we don't have good treatment options. Our insurance companies have denied for decades alternative therapies and left us with only opioids to prescribe if we are attempting to provide relief. So, if you look at the big picture out there, there's been really too narrow of a focus of blame, because the blame is everywhere for our current crisis, and a lack of understanding of the root causes, which are usually social and economic, not so much the supply side.
Right,
yeah.
right.
We're going to, Dr. Feldman, stay right there. So I've got a question that just popped up. Ken asks Dr. Webster, he says, a recent article, Visible Few, described the current moment very well. What priorities for action would be at the state level aiming at legislative and regulatory change, and then at the federal level? So I think what he means by that, in Rhode Island, I have legislation that passed the House unanimously. Should this be tackled on a state level, state by state, or would it be quicker? It would be quicker to get this tackled on a federal level. I just don't see that happening. Do you suggest legislation at a state level?
I think that legislation is really an uphill battle, whether it's national or on a state level. And you've got to keep in mind healthcare and medical care is really determined at the state level. It's not at the federal level. There are federal laws involving prescribing, but there are no federal laws that describe healthcare and how it should be managed, or how we as physicians should conduct ourselves, except with regard to scheduled drugs. So I think our efforts have to be at a state level. I'm not so sure legislation, because it's difficult, but if you think you can do it, you've got somebody in your legislature that will help, that is certainly something to do. But in most cases, it's about bringing a rational discussion about what really is causing the problem, what drugs are causing the problem, and to bring some awareness and a voice of the people in pain who are suffering to the policymakers.
Absolutely. I chose to take my local representative on a social media journey, and it took 2 years, and it started with a crappy resolution, which turned into legislation protecting chronic intractable pain patients. Pharmacists must fill, doctors, legacy patients. And everybody was on board. It passed the House unanimously. But when I got to the Senate level, I felt like I had to start all over. And we have an expression, educate, legislate, and advocate. And it's so important to teach your local lawmakers because, they watch 60 Minutes, and everything has been so hyped up, so sensationalized. This doctor prescribed 8,000 pills. Well, how many patients did this doctor have? So, the media really gets into the minds of people, and it's our job to educate and bring pain patients to these hearings. And, I thought I live in the smallest state in the country, and I still believe if I can change things in this state and then it can trickle over, then it can be done. But it's a constant uphill battle. Pain patients will have good news with the Washington Post or the Times. They'll do some pieces about pain patients, and then we'll get set back. You hear the Johnson & Johnson ruling, and then another doctor is getting put away. So, I really think state by state, and it would be great to have doctors like yourself, fly out to these hearings and testify, and that's what we try to do. We try to raise money to get doctors out, experts, and testify. I don't know if we have another caller just yet. Here's a question. Diamond wants to know, what's pushing the opioid crisis? We seem to be fighting an irrational beat. We use risk benefits for everything, but why are opioids different? Well, that's probably because of the illicit fentanyl overdosing crisis, right?
Well, the reason there is a crisis is because of the number of people who have died from drugs. Now, you often see in the newspaper somebody is writing, we've seen 70 or 72,000 drug-related overdose. The majority of those are opioids, and then they just go in to talk about prescription drugs. And that's very misleading, because when we talk about drug overdoses, we're talking about all drugs. A third of them, roughly, have nothing to do with an opioids, and maybe 2/3 do, but more than 2/3 of those are not prescription drugs. Of the prescription drugs, only about 15,000 out of 70,000 are prescription drugs, and most of those that are involved in harm, overdoses, are not to, from what I understand and from the way I've read the literature, is that you can't tell that those are from patients, but likely 2/3 are not in patients, but people who have been abusing it. But all of the dialogue, all of the criticism is a focus on prescription drugs, not on the real issues and where the problem is. So to answer the question, it's about deaths. Honestly, we've always had a problem with addiction in this country. We had crack cocaine in the 80s. We've had heroin problems in others in years past. The real problem here are the number of people who are dying. If we didn't have the death rate from drugs in general, there would be less concern from our policymakers.
I'm going to sneak in a caller. Hi, caller.
Hello, this is Dr. Ibsen. Hello?
Hi, Dr. Monk. Hi there.
Hello. I have a question for Dr. Webster.
Sure.
Dr. Webster, I really appreciate all you're doing and all you've done, and I've been a fan of yours since I was a resident in family practice in Salt Lake City in 1980 to 83. I want to know, because I'm curious about this, I saw all the trials and some of the trials and tribulations you went through with the DEA. Is that behind you, or is your case still open, or are you comfortable talking about it?
Well, sure. I mean, I've written about it. I wrote about it in my book, and I've talked about it. And, for just to give a background to the other listeners, in 2010, the DEA came in to our clinic with a subpoena to obtain some records. And I had not heard anything from the DEA for 4 years. So it was hanging over me, basically. I didn't know what any of that meant. But at the end of 4 years, because I had a very good attorney, I think, he was able to get the U.S. Attorney General to send a letter and state that they've closed the case. So it is history. It's past. But, here's something for the physicians who are listening. It doesn't matter if you were ever found to have done anything that was inappropriate or illegal. Once you have an investigation, it is like your scarlet letter. I mean, this was 10 years ago now, and you're bringing the question up today. Every time a journalist interviews me, this is something that they have to discuss. They say they have to bring it up. But the point is, this reflects on our ability as physicians to move forward or not move forward. And the fear, if the DEA comes in, justified or not, it has a major chilling effect on physicians.
Sure.
Right. It sort of seems to me like the question would be, for someone who'd been raped, well, didn't you invite that by dressing suggestively, or didn't you have a drink of alcohol? I mean, we're always looking for the guilt. And my investigations are hanging over me, and so I'm specifically curious about how you got out of it. And great legal representation is clearly key to that. And I'm interested where we as a profession could hopefully help each other as physicians. I know we're quite divided. It's like herding cats when you talk to physicians about how they could or should or would behave. But I have found it particularly isolating from the rest of my colleagues to be under the bus. On the other hand, it's also particularly freeing. I mean, I can see that you use your freedom from being in day-to-day practice to write an amazing book, and you're I really admire the movie that you created. So in some ways it frees us up from the day-to-day, but it sure does terrify most of us, doesn't it?
Yes, it does. It is. I mean, it's forever going to be a part of my character, I guess, and that's unfortunate. But I can't change it.
Yeah. Hey, Mark, while you're on the phone, let's talk about Kratom. Dr. Webster, what are your opinions on Kratom? I have a lot of Kratom followers, and they're wanting to know why the negativity. I haven't seen anything written about it, but what are your thoughts?
Well, I'm a scientist and clinician, and most of us want to have evidence about safety and efficacy before we prescribe, endorse, recommend. And there is no scientific support that shows the safety and efficacy of Kratom. It may be the best drug that we've have available out there to treat pain, treat addiction, treat withdrawals, all of which I understand people have claimed it's done wonderful things for. But I don't believe we are responsible as clinicians to say that we can support that without knowing what dose, at what frequency, on which patients, in what condition, and where a certain amount of Kratom should be used. And that there are no controls either on this. And unless you can get currently, even CBD, you can get CBD, Kratom off of the internet, and the concentrations are hugely variable and rarely are reflected by the label accurately. So I think that if it's something that has a medicinal purpose that is legitimate, it needs to be studied, and that we need to understand where it is safe and where it is not.
Yeah, it seems like the FDA is pursuing Kratom with a vengeance. And, they just, in Rhode Island, it was banned. Dr. Scott decided to ban that. But we're on the Massachusetts line. So from many of my patients, even people that I work with in the addictions community, Kratom helped them get off of, when they were struggling with their addiction, Kratom was a godsend for them. But if there were studies done on Kratom, I had Mac Haddo on my show about 4 weeks ago, and he's the lobbyist for Kratom. And they're pushing like a safe Kratom Act. I forget the term, but if studies were done on it and dosing was done, and then perhaps it would be safe and the government would leave the Kratom community alone. But it seems like
to do the right science, to get to a point where physicians like myself would feel comfortable in saying this is okay at this dose for this person, there has to be a lot of work done. That doesn't mean it's not valuable. It's just we as physicians want to know as much as possible about the safety and efficacy before we can endorse, prescribe, or support the use of most drugs. Now, there are some that we know are safe, really safe, that we that we don't have to have that same level of science. But for the most part, I think that's where most of us fit.
May I counter that or add to it, if you don't mind? May I?
Sure.
I can see that the scientific model is based on multiple ways of knowing. And of course, double-blind placebo-controlled study is felt to be the most reliable way of knowing. I don't know, and you and I cannot prove the sun's coming up tomorrow. And the study's never been done. There are some precedents, billions of days have happened. But if the sun doesn't come up tomorrow, we're not going to be particularly worried about whether or not we can prove it. And the experience I've had with desperate patients who have no option is people will treat their pain if it's above a 7 or an 8. And they'll do anything to do it. And I think in the realm of harm reduction, the question for me and my patients is, are you stable? Are you able to go to work, love your grandchildren, take care of your family? And of course, most of the opiate refugees I saw, as everyone in my state stepped away from opiate pain management, those people were desperate. And what I fear, and we haven't studied this well enough to know, and there isn't even a study about what's happening with the consequences of the CDC guidelines. But it seems to me that when my patient comes to me and says, I'm only going to do this a little bit longer and then I'm going to blow my brains out, that would be something that I ignored until 3 of my patients did it. So it is the pain and anguish of my own PTSD from having my patients kill themselves that has me say, well, it's not safe to seek the illicit pill market because those are contaminated with fentanyl. You're surely going to die if you do that. And then if somebody tells me, well, wow, I had a great result with Kratom, and I've seen some patients who are very desperate get better with Kratom, and they're still alive, and I guess I use that as some evidence. It's not good evidence, but it's also, these are people who are looking for any port in a storm. This is like questioning whether a life preserver is going to hold you up or not, or make you sink. And, those haven't been studied either.
I understand your point. I think I understand your point. I mean, the bottom line is always what we can do at the moment for our patients, and what's the risk and what's the potential benefit. And I hear you. There are sometimes no other options. However, I don't know what's in any of the Kratom products, and so I'm not going to say no one should take it. I'm just saying, as a physician, as a scientist, I can't recommend it without more study.
Absolutely, and I respect that. Thank you so much.
Thanks, Mark. Dr. Webster.
Thank you, Dr. Webster.
Thanks,
You're welcome.
Mark. I'll talk with you soon, Mark. How do I phrase this? I've got a real problem with the medical boards around the country. Just in Rhode Island, do you think the medical boards need to be policed? Who's policing the medical boards? The governor. But really, it seems like the medical boards are getting away with a lot right now. Do you think they should be policed?
Well, I don't know that I would use that language. I think that the medical boards are responsible for the medical practice within a state, And whether or not they are doing a good job is a different issue. And how they do it may be of concern. And I have major concerns about how they're addressing people or physicians that are prescribing opioids in many areas. I've been trying to help a number of physicians who have been inappropriately criticized by medical boards for their prescribing. And that's largely because the medical boards are made up of part of society and doctors who really don't know much about the field, about opioids, and they've been hugely influenced by the mass media and the general attitudes. I see even hospital systems sending out notices to their physicians that they must comply with the CDC guidelines, just like the major pharmaceutical change. And there's no attempt here to try to individualize the therapy and recognize that some people may need something different than what is prescriptive, and that the CDC has recently said should not be applied as a one-size-fits-all. But that's been largely ignored. So to answer your questions, I think the medical boards are not very well equipped to address this issue because they're not peer-reviewed in the same way in most instances.
And there's like 12 board members, and 2 of them are in law enforcement in Rhode Island, and one is maybe a podiatrist. You have to have an allopath, that's probably not the word, an osteopath. And when I did research on the medical board, I said, there's no pain management doctors on the medical board, yet they're persecuting pain management doctors. So if you don't like the word policed, what word would you use? What word should I use?
Well, it depends on what is the question. Are you asking me how the medical board should interface with doctors who are prescribing?
I'm wanting to know, how can medical board members be held accountable for the havoc they have wrought upon doctors? They've taken away their livelihood. They've tarnished their name. They'll never be able to get back their good reputation. Patients don't want anything to do with them, and they're ostracized by their peers, all because of some shitty medical board people. And there should be a committee, just like with the police department. We have a watchdog group. We police the police now. I'd like to see something done where we're monitoring medical board members to be sure they're not abusing their power. Because let's face it, they've got a lot of power, right?
They do. They have ultimate power over a physician's right to practice medicine, and that's the way it's always been. I think there are times, as I've just said, that I certainly disagree with the decisions of the medical boards, and largely those occur when there are no experts in the field. And so it's not peer review. And so there may be a need for something different, like you've just outlined. It's not my area of expertise. I do think that there's been injustice with a number of physicians, but at the same time, I think that the medical boards, I think that there are a lot of physicians who need to be disciplined. And so that the rest of the physicians who are doing a good job can continue without being frightened that they will be persecuted.
Yeah. So many times when I'm brought in to advocate, a doctor says, "Oh, my hands are tied." I said, "By whom? Who tied your hands?" The CDC? No, the Dr. Scott, my director. Dr. Scott said I can't. I said, no. Nobody ever said you can't. Those are guidelines. If you want, guidelines. I said, no two bodies are the same. What works for me may not work for somebody else. What's the reason? He's like, I don't want to lose my job. I don't want to lose my family. I don't want to lose my home. And I'm not putting my life on the line to prescribe. So for doctors now, it's easier to not prescribe. Another question just came in. Is the DEA hampering treatment of chronic pain going back to 2005?
Hampering treatment. I think that I think that, and I mentioned this to Claudia the other day. I think that there are cowboy rogue DEA agents, as there are cowboy rogue physicians, and probably in every field. In that today, I think that there is certainly a shift to more law enforcement and interpretation of what is a legitimate medical practice that is hurting patients. And that's probably top down, to try to interpret what is legitimate medical practice in a way that I don't believe it was ever intended, but I'm a physician, and it's often being interpreted by judges today and by juries.
Ginger asks, why hasn't the FDA defended itself against the gross overreach of the CDC? Do you have an opinion on that?
Well, we don't know that they haven't. I think that the FDA probably does things quietly. It's part of the same health and human services organization, CDC, FDA, and all of the government organizations are really a part of the same house, and they're not going to go out and throw mud at basically a different branch of the government. They're going to do what they can to influence, and here's evidence of that. The NIH, Interagency Pain Management Task Force, has come out with recommendations that really do counter what the CDC has said, and they're very thoughtful recommendations, and basically are kind of a guideline too. And that they did that without saying the CDC is wrong. They just massaged basically what has been said, and actually supported by the CDC recently in the air of interpreting the CDC guidelines. So I think the FDA and NIH are doing what they can do to do the best for the society. In the face of what I think has been a real error on the CDC's part.
Do you believe, a lot of chatter about this, were the CDC guidelines created in secret, and did PROP have anything to do with the CDC guidelines?
Well, let me just take the first part. Yes, they were for the most part secretly developed, and there was very little opportunity for outside input and review. Whether or not PROP was involved, there were members of the PROP group that were involved at one stage or another, but I don't know to what extent PROP controlled or even influenced the outcome. I don't know. They may have.
So 10 years ago, when you stopped seeing patients, what happened to your patients? Were they sent, did you have quite a few pain management centers?
Yeah, we had, well, not centers. I had one clinic. We had 8 providers. We saw 5,000 patients probably over the previous 15, 20 years. And many patients had been with us for 1 to 2 decades, maybe even longer. Now, I had announced basically 6 months to 9 months before I stopped seeing patients that I was going to transition to do just clinical research. And I recruited a gentleman just out of the fellowship to come in and take over the practice. And so basically, I gave the patients an option of going, and I gave them a list of where some of my doctors, the doctors that were in my clinic, went to set up their own practice. But one of them was willing to take on all of the patients that didn't go somewhere else. So that was a very, very important issue for me, in that I wanted to be sure that they weren't abandoned, that they were taken care of, and I helped financially support the new doctor during a transition so that the patients could continue to be seen as they were in the past.
Yeah. It's sad, right, when you think about it? Dr. Webster, before people take their lives, they'll message me. and we'll have a conversation. And I try to give them reasons to not take their life. And, I'm like, maybe can you hold on another year? What can I do? What words can you send to the listeners, the people with pain? What can you offer them in for hope at this point?
I think there are a couple of things. The first is that there are physicians like you have had call in today who really care about their patients. They really care, and they risk their careers to help them. They're not all of the physicians out there are not doing that. But there are a lot of physicians who care. There are a lot of other people who care. You care, Claudia. You have done this for people like the ones you're talking about. You've done this to help them. So I think that patients that are listening should understand there are a lot of people who really do care about them. Not enough, and that we need to do more to bring society along and policymakers. But the other thing is, as I said at the top of the program, there are a number of treatments, a number of drugs, I think, in development that can be revolutionary in the field. There is a particular disease that we call congenital insensitivity to pain. That means if you are born with that genetic defect, you have zero pain. You can never have pain. The life expectancy is short because you break all of your extremities, you touch your hand on a fire, and you get burned and infection. So they don't live long without some ability to feel pain and develop reactions to pain to avoid harm. Now, what we know is that, or what I'm working on with several companies, is how to dial in some of that genetic defect in a therapeutic way for periods of maybe a month, maybe 6 months, so that we may not provide 100% pain relief to people, but if we can provide 50, 60% pain relief for most people, that will be huge. Because most of the time, people with opioids, even the best of situations, 35% pain relief. That's huge for people with a pain level of 7, 8, 9, over 10. But if we can take away a majority of their pain by dialing in something that we know Mother Nature has gifted us with in a defect, in a mutation, then we're going to make a world of difference for millions of Americans.
Okay. I know this is a question. I get asked this all the time. A lot of doctors are writing scripts for Suboxone for pain, and it's not been approved by the FDA. What are your thoughts on treating a person for pain with Suboxone?
Well, it's really Belbuca, and it's really buprenorphine. But there is a buprenorphine called Belbuca that has been approved for pain, and I think that there's a subset of the population for whom buprenorphine can be wonderful in the treatment of pain. And I used it a great deal when I was in practice, although I used Suboxone because that's what was approved that was available back then. I used it for people who couldn't control the amount that they would take of their opioid. And you would...
That's common.
Yeah, that's very common, and it doesn't mean you are addicted. It just means that most of the time it means you just can't tolerate the pain, and you're going to take more than what has been authorized. So, but that can be dangerous. And so, in some instances, I would use the Suboxone and say it is for pain, and I was able to get it approved sometimes, and sometimes it worked. It did not work all of the time. But I think that if you can use buprenorphine, and Belbuca is approved, or you use Suboxone off-label, it's still buprenorphine. I think that is a good option for some people. It's not going to work for everyone, but like everything, we have to individualize our treatment. That's why this, one size does not fit all. Everyone's going to need a different dose. A lot of people respond to one type of medicine and do not respond to others, and vice versa with a different patient. We have to find the right treatment for that particular patient and the right dose for that patient.
And when I testified before, some of the dumbest people God ever created on a local level, they just believe everybody just, you get 3 pills a day and you shouldn't need any more than that. My God, if you need more than that, you must be an addict. And it's so important to educate. So many of these laws, we started off with the CDC suggested, the 90, that's the powerful 90, right? But then other states started to adapt their own. So Rhode Island adapted 60. So if you're going to prescribe more than 60, you have to do the following. And other states are grasping onto the number 40. And you wonder, where are they getting these numbers from? Do they go by... and it seems like our studies are based off of, they're treating people with pain based off of addiction studies. Makes no sense. I think it's important to separate pain from addiction. Just focus on pain.
I'm sorry, what was the question?
I think it's important for us to, when we speak with our lawmakers, to focus on pain and remove addiction from the equation. We shouldn't be lumped into, the people with pain shouldn't be lumped into the addictions community. They're different communities.
Well, they are. However, there is an overlap. There are people who have serious pain as well as a substance use disorder. And you have to keep in mind, pain as well as an opioid use disorder are spectrums. They're not switches where you have it or you don't have them. There are spectrums, and these spectrums are like Venn diagrams, where there can be an overlay of a substance use disorder, an opioid use disorder, and people with chronic pain. Chronic pain can drive the aberrant drug-related behaviors. Aberrant drug-related behaviors can lead to more pain. So it is important, I think, that physicians understand these concepts, and where there may be an overlap of the two. They're not really inseparable, because unless we're not using opiates or any other drug of abuse, because we need to know if that drug is now no longer really addressing the primary pain problem, and that somebody begins to use it and self-medicate for a different problem. And I think that's really important.
Okay. Dr. Webster, how can people learn more about you? People are asking, they want to follow you. So are you on Twitter? What's the best way to follow you and your work and what you're doing?
I am on Twitter, I'm on LinkedIn, and I have my blog. Probably the best would be to go to Lynn Webster, Lynn R. Webster, MD.com, and there you can see all about me, and you can see the documentary, access to the documentary, but mostly follow my blog, because I post that on a weekly basis. And you can go back and see for the last 3 or 4 years I have basically a weekly blog.
Good, and I know the victims of sexual assault and who have been denied access to pain management. That blog is so important to them, and that's going to be out with a week next Saturday. So that's good news for listeners. And there's some hopefully in about a year or so we'll have some medication for people with pain. And I just want to say thank you for taking.
Claudia, let me just say that to your audience that they should look for clinical trials where they can participate in some of these new treatments that I am studying myself. You don't have to live in Utah, but because these will be offered elsewhere. And that's the reason I got into research in the beginning, was because I wanted my patients to be available to have the newest, the best in the pipeline that one day could help them the most.
Okay. And how do people find these clinical trials?
Maybe I'll write a blog about that because usually
you're going to be blogging a lot.
Yeah, well, I do blog a lot. Yes. But you can usually just tell, clinical trials, where you just type in clinical trials for pain, and there should be something in Google.
Great. Hey, thanks so much for joining us. Listeners, doctors, don't forget, we protest again on October 16. A week from tonight, we have Dr. Jeffrey Singer from the Cato Institute. And then on September 29, we have attorney Dr. Dan Laird. And, we hope to make, to the listeners out there, we're working day and night for doctors, for patients, for pharmacists. We're really trying to collaborate. I'll see you folks in a week, and don't forget to get out there, protest on October 16th. The Don't Punish Pain Rally organization is the first organization to protest on a national level and receive media over 500 times. You need to get the media involved. We've done one hell of a job. We're not giving up. Thank you so much for tuning in. And remember, I get my strength from your strength. Have a great night.
Thanks for joining us for the DPP Rally Talk Show. Subscribe to our channel at DPP Rally Talk Show with Claudia on YouTube. Copyright 2019. All rights reserved.